And the second apology I have to make is I reordered my slides this morning with Marita and actually forgot to reorder the references. So you'll find there's a slight oddity within the chronology of the references, but the numbers next to them do actually represent the references as they're referenced on the slide. So thank you very much to the organising team for inviting me along, particularly Marita, and the excellent communication that we've had over the last few months about this conference. I'm very grateful to be invited, and thank you very much indeed. I'm going to talk to you a little bit today about a project that we've done called the Proactive Assessment of Obesity Risk During Infancy project, and it's really, I'm going to talk about the feasibility of implementing an intervention into health visiting practice. The picture is pertinent. My 14-year-old son loves me presenting this. But I also, I chose it deliberately a while ago because I think it's a little bit about balance, really. I think there's a balance here around, we have evidence for the risk factors for childhood overweight and obesity, and we know about that, but how do we communicate those to parents in a way that's sort of non-stigmatising and acceptable to them? So I do see this very much as a balance. I hope you can read this. This project included a rather large team, and I want to acknowledge all of their contributions on this particular project. I won't go through them for now, but I think the copies of the slides will be available. So mostly in the room, I won't need most of this slide really, because you're all aware that the risk factors for childhood overweight and obesity can be identified antenatally or during infancy. The study that we did, a systematic review back in 2012, and I appreciate that there's more new epidemiological data since then, identified pre-pregnancy weight, smoking during pregnancy, infant birth weight, and rapid weight gain largely as the strongest risk factors. Now, we did see gestational weight gain in that model, but there wasn't enough data at the time to include it, but it is there, and I acknowledge it. So some of the epidemiological studies from around the world have shown that sort of 25 to 33% of infants gain weight more rapidly than is desirable in the first few months of life, and that this is associated with genetic markers for overweight, but it may also be modifiable. So we all know that we're all talking about early life being the critical period for establishing dietary intake patterns, eating habits and food preferences. What's novel about this work is that we've been trying to use interactive digital technology as a way in which we would communicate this information. It has been used previously to support sensitive discussions about risk, and certainly within the adult cardiovascular literature, there's been some success about delivering personalised information about risk status. So I guess the way that we were trying to look at this was that the behaviour change could potentially occur through the neutrality of the technical device. So we know that health professionals struggle to raise the issue of overweight risk, particularly with parents of very young infants, and we kind of hope that having the kind of third eye in the room might help to reduce some of the sensitivity within those discussions. So ProAsk, which isn't the greatest title in the world, but it was the one that Judy Swift came up with, and then we applied for the funding and then we got it, and so we're now stuck with ProAsk. It's an overweight risk assessment tool, not obesity, but obesity is in all the literature, so I have to carry on with it. So it's a digital tool, so it's delivered on a tablet device, and it includes a validated algorithm, which we call the Infant Risk of Obesity Checklist, and also some preventative strategies which are contained within a wheel, which we developed from the systematic review that we did way back 2013 to 2014. So we had a lot of discussion about how we might convey this information about overweight risk to parents, and this went from providing red bricks, red lines, amber traffic light systems right across, and the group was very divided on how we might communicate this visually. So we ended up with this sort of very simple system, which was 2 green bricks, one of which suggested that the infant would be at population risk, so we're all at a certain risk of developing overweight and obesity, and the other one would suggest that the infant would be at above average risk of being an unhealthy weight, above a healthy weight when they became an adult. Later qualitative interviews revealed that that was too soft, and many parents said they recognised the red, amber and green system and would have preferred that. So we perhaps didn't quite get that right. So the intervention itself, as I say, was the infant risk of obesity checklist. So going through a checklist to identify overweight status. And then these options to support a healthy weight gain via this therapeutic wheel, which had these components on it which you'll all recognise: active play, milk and solid foods, physical activity and baby soothing techniques. And we took those from the systematic review and worked through those with a parent and a health visitor and a dietitian to try and get the wording in those right. The middle bit has an area for parents, which talks about reassuring parents around the risk status. The other bit of the intervention was the motivational interviewing. So what we were asking health visitors to do was to run through the checklist for parents whose infants were identified as above average risk, to go through this therapeutic wheel using a motivational approach and asking parents to come up with a goal, a behavioural goal, and then following those parents up over time. So very, very briefly, I mean, I have to state that this was a feasibility study, so we weren't looking at outcomes. And we use this framework, and if anyone's doing a feasibility study, this is a BUGGEE framework, which was published in Trials, and they have an absolutely brilliant way in which you can work through whether or not your feasibility study was successful. And I'm going to show you a little bit about that, how that worked in a minute. But really our objectives were around trying to determine whether the proportion of infants calculated as at risk and comparing that with the population, so that we could calculate a sample size, to look at recruitment response and attrition rates, to look at the feasibility of health visitors delivering this, parents' view and health visitors' views of it, how well health visitors adhered to the protocol and intervention fidelity, and then to look at whether we could collect the data that we wanted to collect. So the outcome measures around weights at the different time points and the other sort of baseline data, infant feeding questions, feeding data, etc., etc. So it's really looking at whether we could collect this data, not what this data actually shows. So the health visitors and their team had one-day training in ProAsk and adapting the motivational interviewing they already had to our study. We trained the health visitors and the nursery nurses and the administrators, because we felt that everybody involved in the study ought to be trained and ought to come along and have a nice lunch and engage with the process. So there were 4 sites, 2 in the centre of Nottingham and 2 in Cambridgeshire. We did have the most deprived sites in those areas that the health visitor managers said, well, you can go and work there. We asked health visitors to recruit parents, they asked to identify parents for us at the 6 to 8 week check, and the parents were then referred on to the researcher, who went round to the house, formally got informed consent and brought them into the study and did the baseline measures. So when I say the 7.5 to 7 month period, it was meant to be a 3 month period of recruitment, but we had to extend it. So one Nottingham did 5.5 and Cambridge did 7. The health visitors undertook this overweight risk assessment with the parents at the child age 3 to 4 months, and then were asked to set up this goal setting exercise and to revisit that with the parents. And then we did some follow-up measures and semi-structured interviews after the study. This is what happened which I'll unpack a little in a minute. So these are kind of leaky pipeline around recruitment. So we checked the NHS Child Health records, and there were 589 parents who whose infants had a 6 to 8 week check during the study period. But only 324 were screened by the health visitors. So only 324 came into any part of our study. They approached 226 and 138 consented to have their names passed on to the researcher. 66 completed their baseline questionnaire, 56 had a risk assessment, and 53 of those of the data got transferred, and we got 34 responses back to the post-intervention questionnaire. So a bit disappointing, to say the least. I'm not expecting you to read all of this, but I just thought I'd put this in because I think it really helps us understand what a feasibility study is trying to do. So what it's trying to do is to work out whether you can calculate a sample size from the measures that you collect. So how many infants came into the study and how many had complete assessments. And I think we could calculate a sample size, but as you're probably already hearing, I think going forward with a randomised controlled trial of this work is not feasible. So interestingly, when we did the initial look at this, we were informed by the health visitor managers that we would get 700 children across those sites within 3 months. So we actually got 589 within 5.5 and 7 months. So that was a bit of an overestimation. So, you know, again, we're sort of losing numbers here, there and everywhere, really. Health visitors obviously screened a lower number and recorded a much lower number as eligible for the study. As I said, 66 parents were recruited. We were hoping for 100, and our calculations should have allowed us to get there, and I can talk to people about that a bit more in depth if you're interested. Not all health visitors took part, so 28 were trained, 22 took part. 88 parents refused to participate in the study, and so we you know, the numbers just dropped and dropped. In terms of the intervention, so we've got the recruitment part of it and then the intervention part of it. So I say 56 infants had the risk assessment, but only 5 of the infants who are identified as at higher risk actually received the intervention per protocol. 6 health visitors declined to take part, as I've said, and 88 parents refused to take part. And we got quite a low number of parent questionnaires back, which wouldn't really hit a criteria for ascertainment. We should be looking at getting around 80%. It was difficult to collect some of the data. As you can see, some of the anthropometric measures, we were unable to collect that data because some of them aren't routinely recorded in clinic anymore, and the researcher going out wasn't trained to be able to do this. So, and I think the other couple of things which are of interest were things around the logistics of running a multi-centre trial. So one centre recruited much better than the others, and the researcher, there was a Cambridgeshire centre, the researcher going in said that this team functioned incredibly well, this health visiting team. They worked very well, they had worked very well together for a long time. Others, there were staff changes. One area they really didn't like their line manager, and he had asked them to become involved in this study. So there are all sorts of reasons why health visitors may not have been quite so signed up as we wanted them to be. And finally, in terms of the components of the intervention working together, so if you imagine we have a risk assessment, a checklist for health visitors to do, and then we're asking them to take on a motivational approach to goal setting. And in some of our qualitative findings, I think they found that incredibly difficult. They go in the room, we ask them to tick a box and come up with a score, and then they have to move into a different approach. And I think that's something in the future we need to think about. And the final thing is that we did, when we delivered the training, we delivered it in February, and we didn't actually start the study till the April, and a lot of our health visitors said the gap was too big. But as those of you who run trials will know, getting a whole team of health visitors in a room in your diary requires a certain amount of planning, and we had a mismatch in timing. So very briefly, because I know I'm going to go out of time. So I've already talked about the assessment. The risk assessment was on 56 infants, and data was transferred to 53, so we had some problems with data transfer. 40% of these were identified as above population risk. There were differences, statistically significant differences in the weight for age Z-score between the above average and the average risk groups. But remember, this was done at 3 months, so any kind of rapid weight gain isn't probably going to be within those standard those Z-scores. So I suppose positively we could say that some health visitors were able to collect data and calculate overweight risk for study infants. How much time do I have? 5 minutes? Okay. Quick process evaluation. So we did interview the health visitors and the parents after the study had finished. 15 out of the 22 health visitors came forward for interviewing, and 12 out of the 66 parents. Now I'm talking about a process analysis here. Jenny Rose, who's worked with me, has done a much more interpretive analysis, which will be the part of the second paper, but I'm just going to talk about the sort of process analysis, so we're not looking at great depth here. So the two main themes, unsurprisingly, were recruitment challenges and around the intervention acceptability, fidelity and protocol adherence. So Pinky, I'm not going to meet your eye here. We had a site in Nottingham where 90% of the parents were non-English speakers. We'd been asked to go into that site, and we had been promised interpreting and translation services, although there was no translation for the tablet. But when it actually came to going out and doing it, there wasn't sufficient staff to provide us with any interpreting services, so this was kind of cut off right from the start. So the health visitors working in those areas obviously said that they couldn't recruit parents in who didn't speak English, so that was one barrier. And we have to put our hands up to that as being a study team error. What was more concerning was that a number of parents were not referred to the study team, not because the health visitors perceived they didn't meet the eligibility criteria when they actually did. So we had some eligibility criteria around postnatal depression diagnosis, but the health visitors took away from that and didn't refer parents who they thought had any mental health difficulties, safeguarding difficulties, where there was domestic violence, because they felt this might overburden these families. So those that had some mild depression, chaotic families with safeguarding did not come into the study, and that was of quite concern. And when I presented this to a group of student nurses, some of whom had mental health problems, they were appalled, absolutely appalled at this gatekeeping. So it's really difficult. So a lot of the health visitors weren't signed up, and I think work's needed at that level. So they said that the managers wanted them to do it, they've been asked to do it, they've been told to do it. They weren't signed up to do this study, and it was just too time consuming for them. They also felt that some of the parents were quite anxious about having a researcher they didn't know going into their home. So although the names of those parents were passed on to the researcher, when the researcher rang, that they were either not in or didn't want the researcher going round to their home. Not long now, I promise. Oh, sorry, I've just jumped ahead of myself. So I'll just move forward. So they also used the therapeutic wheel, which we'd asked them the health visitors, we'd asked them to come up with a goal, but it was used pretty much universally, so that the parents saw all the information on the wheel, rather than selected information with goal setting. And as you've just said, Eleanor, that approach of providing all the information isn't always terribly helpful. So I quite like this quote. I know you said to discuss one topic, but we ended up discussing them all, because all those topics are covered in health visiting anyway. To me, it didn't feel right that we talked about diet without exercises and feeding cues. That was a point. The parents really liked the intervention. They liked the digital tool. Quite a lot of them actually helped the health visitors to use it. So they were really keen. And the health visitors said it was quite a helpful way of thinking about it. But some of them did have concern about raising overweight. And I'll finish with my conclusion. I'm sorry if I've run a little bit over time. I do apologise.
Thank you very much.
Okay, thank you.